Good evening, everyone. I hope everyone is safe and well in this very challenging time of crisis. My name is Grace Sun. I'm the current president of NYSOS, and I'm also a comprehensive ophthalmologist here at New York Presbyterian Cornell. And I also am the program director there for the residency program. So I wanted to thank everyone for joining us on this webinar, and thank you to our guest speaker, Jennifer Kirschenbaum. She is our legal counsel and an expert in healthcare and healthcare practices. We also have a few members of our board who are participating as panelists. We have Gary Hirschfeld, Peter Menger, Ira Udell. We also have Paul Orloff, and we have our executive director, Robin Pellegrino. I also believe Dr. Dan Rosberger, who's a retina specialist in Manhattan, will also join shortly as a panelist. So this is undoubtedly an extraordinary, challenging time for us as physicians, and in particular as ophthalmologists. As many of you know, we as ophthalmologists may be at slightly higher risk of the COVID-19 transmission due to the nature of our exams. But the purpose of this webinar is actually to update our members on the legal environment during this healthcare crisis, as many of us are thinking about practice management issues, and people have to consider perhaps employee layoffs, emergency planning, insurance claims. So we have a presentation by Jennifer, which will be followed by some comments from our panelists, and there will be some time for Q&A. Please keep in mind that we continue to have our executive director who's available for questions. Many of you have been emailing her, but we will continue to schedule these webinars as new information continues to be available. So I'm going to turn it over to Jennifer, and she's going to start her presentation. She has about a 30-minute presentation. A lot of information that I think that you guys will find very helpful. And then afterwards, we'll have a moderated discussion. So thank you. Jennifer?
Thank you, Dr. Sun. It's, well, I would say it's my pleasure to be giving this presentation, but it's not. I'm sorry that we have to be briefing everyone on the information I'm about to present. We're going to go through a lot of information. There's going to be a lot of language on the slides, and I apologize for that. It's not how I like to do most of my presentations, but there's a lot of information I have to get out there, and then we will talk through and hear how your colleagues are handling the scenario. I have pulled from resources and authorities that will go through, so all governments, some from New York State and some from federal. We do have some idea of what the federal legislation is going to look like now, although it's not finalized, and we'll get to it. This is what I'm going to cover, and then we'll turn it over to the panel. I'm going to go over what essential services are, the legality for health screening for patients and staff. We're going to go over the sick benefits that are available. I'm going to go over the federal law, what it looks like right now. Sorry, it's still a bill. It's not the law yet, so it's going to change. We'll talk briefly about some business elements, approaching landlords, telemedicine, and then we're going to talk about termination, because some of you may be making the decision to terminate certain staff. And then we'll talk about, in the frequently asked questions I've been getting, we can actually do that with the panel. So can you stay open is the first question. I think many of you have thought an answer for this already. The answer is resoundingly yes. Under New York State executive order, Governor Cuomo's order for pause, medical personnel are, of course, in the category of essential, and they are essential healthcare operations. So anyone who has a quote-unquote hospital that's Article 28 license, AM-Surg, office-based surgery is an outpatient, and any private practice, doctor's office, you are authorized to open. In what capacity, we're going to talk about. Before we get there, I want to talk about whether or not you can screen patients and staff. The answer is absolutely yes. All of the sensitivity around certain questions in the environment prior to COVID have now been somewhat paused as well, and you were allowed to ask questions on whether or not patients and staff are symptomatic. If you're going to stay open, this is from the academy, and this is what they're advising you to do. They're advising you to ask patients if they have fever or respiratory symptoms. Has your patient or their family members traveled recently? They want to ask that, although with community spread, I think that's a little bit outdated. The CDC is urging healthcare providers who encounter patients to immediately notify both infection control personnel at the facility, and this way we can take some additional steps for sterilization, which we have some recommended protocols from. So this is also from the AAO website, and that information I encourage you to peruse in your own time. I'm not going to read through everything, but these are some recommended protocols when you're scheduling or seeing patients. They want you to reschedule appointments for patients with non-urgent ophthalmologic problems and avoid using equipment that cannot be safely disinfected, such as some visual field analyzers at this time. They're asking you to not use. If the office setup permits, patients who come to an appointment should be asked prior to entering the waiting room about respiratory illness. You're authorized and encouraged to take a temperature of patients and staff as they come in. You can ask patients to wash their hands as they come in. I know some practices are asking patients to wait outside or wait in their car until the current patient that's being seen is actually vacating the premises to encourage social distancing. Some other straight from the academy, the use of commercially available slit lamp barriers or breathe shields is encouraged. And then they also give recommended protocols, which we'll get to on sterilization. Can I say open, elective versus emergency? Sorry, the reference here is wrong, but emergency is for any person where they are afflicted with such a condition in serious jeopardy or in case of a behavior condition, placing the health of such person in serious jeopardy. So the thought process of maintaining our private practitioners is essential is to offload some of the potential volume that might be going to an emergency room. So if there are emergencies for your patients, the public is asking that you do open and that you do see the emergency appointments. This is also from the academy, straight from their website. They're giving guidance on how to triage for ophthalmology patients. They're asking that for routine visits that they be rescheduled, and we wait until we have clearance from public health authorities. The dates that are floating out right now are third or fourth week of April, which of course can absolutely be pushed out further if for non-emergent visits. Urgent ophthalmology appointment for a patient with no respiratory illness with standard precautions in place. They are saying that that is appropriate for you to be seeing. Urgent ophthalmic problems in a patient with respiratory illness symptoms, but no fever. The patient can be seen now in an eye clinic. The patient should be placed in an examination lane immediately with the door closed, so they want to be just right into the room and isolated. Gowns, gloves, and eye protection are recommended, and the examining room must be cleaned after examination. Now, this is for urgent visits. They are for high risk of COVID. They are asking that those patients actually be sent to the ER, to the hospital. Do not see these patients in your office. An urgent problem for a patient that's documented with COVID, also straight to the hospital setting. So please do not see these patients in your office. Considerations for emergency care. In response to the state of national emergency, there are pressures in the community given that you should seriously consider, of course. We want to make sure that you think about that before you start scheduling any type of procedures that are emergency. Elective surgeries have to be pushed off. We have CDC guidelines that are available, and they are inclusive for our New York area. So please review those before you decide who you are going to see and schedule. For outpatient clinics, and this is straight from the academy, ophthalmology offices should provide only urgent care, make efforts to decompress their waiting areas, and consider alternatives such as encouraging patients to wait in other locations. I can tell you hand washing, of course, again, I said it already, but that's the main thing that you can see on every single list when you look at it. Elective surgical procedures. So the American Academy of Ophthalmology is supporting the following recommendations: delay all elective ambulatory provider visits, reschedule elective and non-urgent admissions, delay inpatient and outpatient elective surgical and procedural cases, postpone routine, sorry, I'm not sure where this is from, the dental and eye care visits. Circumstances are going to vary. If you're seeing any language floating around that hospitals are supposed to be reporting bed occupancy, because I've seen that, and owners of ASCs are questioning, and also office-based surgeries are questioning whether that applies to them. The answer for the OBS is no, you're not required to be finding additional beds to put into your OBS. That's for general hospitals, freestanding hospitals. Okay, so moving along, because I think we're getting a sense here. I do want to answer the question now of, Jennifer, what happens if I do happen to see an elective visit? What's going to happen to me? Well, the state has the authority to come in and shut you down and to fine you. So if you don't listen and you do remain, for the most part, open and for not just emergency visits, there may potentially be ramifications if that becomes known. And so you should just understand that and try to abide by the guidelines at this point. This is straight from the AAO. Environmental cleaning and disinfection recommendations. They're giving guidance here that is quite specific for cleaning, and I think many of you have probably already gone through some of this language, so I'm not going to spend time reading it, but I will say that if you've not spent time just looking into what is effective to kill COVID, there is guidance at AAO, and I would encourage you to please take a look and just make sure that everything is sterile. Okay, if you are going to close your office, or if you're going to have changed hours, which is very likely during this time, what do? You have to notify your patients. You have to inform your patients you're no longer open for non-urgent care, and you should actively reschedule their visits, and we can talk about with the group whether or not we think that May 15th, May 1, May 25th, when do we think the date is that we should be looking to push out our elective services? And that's a good question for the panel. You should inform your patients that you remain open for urgent care if you are going to remain open for urgent care. And if you are not going to be seeing those visits, then I would recommend that you direct your patients to where they can go during this time period. And of course, if there's any life-threatening issues, then they should be directed to 911. For sick employee benefits, and this is a big deal because this is all new information for us from state and federal that I'm going to go through, and then we can answer questions after the fact. So let's talk about it. And these are already passed and signed, and this is law. So under New York state law, we are now required, if we are an employer of 10 or fewer employees, job protection. That's what we have to give. If we employ more than 10, 11 employees, and we have a net income of more than $1 million, we are required as of today to pay 5 days of sick leave to an individual who is under quarantine or isolation, not an individual that we employ that has anxiety. An individual that has a legitimate medical reason to be under quarantine or isolation is entitled to 5 days of PTO right now for COVID. If now, related to quarantine, if you are quarantined but working from home, you are not qualifying from these benefits because you're actually working. You may be eligible for additional leave under New York State Paid Family Leave, which we'll get to, but I'll tell you now is New York State Paid Family Leave is the essentially insurance fund benefit that your employees are entitled to take care of another human being. If your employee, him or herself, is sick, then they would be entitled to go out on PTO or disability potentially. Maternity, paternity, that's to care for another human being, a baby, which is why they qualify for New York Paid Family Leave. Okay, so these are just some frequently asked questions from New York. If you work for an employer with 10 or fewer employees and your employer made less than $1 million, what do you have to do? You're not entitled to any PTO, but your job will be protected while you are home, potentially fighting COVID. If you work for an employer that has more, which we covered, 11 or more, then you are entitled to your 5 days of PTO. Now, I'm going to just skip through this because it gets complicated and there's a lot of information in here, but this is going to change. As of April 2nd, which is next week, the PTO that has to be offered is going to change. So if you wrote all that down, that counts for this week and this week only. Next week, as of April 2nd, the employer is going to be responsible for 2 weeks of paid time off for an individual that is believed to have COVID and is home for quarantine or for isolation. So, and this is going to apply for all small businesses with fewer than 50 employees, anyone under 500 employees, everyone's going to qualify. If you think that you're entitled to an exemption because this is going to create a financial hardship, you can try to apply, but the government has to give you that exemption for you to get out of it. So these are the reasons why under the federal law that's going in April 2nd, you would be entitled as an employee, the employer you'd have to pay, you would be entitled to some level of leave. If you are home because you are quarantined, if you are caring for another person who is home because they think they have COVID or they know they have COVID, or, and this is what you've heard a lot about, you have an employee who is home caring for a son or daughter that is not in school. And this is any age 18 and under. If they are home, they will receive a benefit. What is that benefit? If the employee is home sick themselves, they are entitled to 2 weeks of PTO paid. Okay, that's if they're home sick themselves. If they are home caring for another person that is believed to have COVID, they are entitled to 2 weeks at 2/3 of their regular rate of pay. Okay, that's what they're entitled to. Now, if they are a caregiver to a child who is not in school, they are entitled to the 2 weeks for the PTO, plus an additional 10 weeks of this Families First Coronavirus Response Act coverage. And that is capped for the caregiver at $200 a day. So they get up to $12,000 worth of benefit over 12 weeks period that the employer is responsible to pay out. This is if you have an employee as of April 2nd and that employee makes a claim that they must stay home to care for a child, the employer is responsible for paying out. And this is for any business unless you receive an exemption that's under 500. The larger companies have different responsibilities. So this is going to be paid back dollar for dollar to the employer through a tax credit. So when would you see that back? Your guess is as good as mine, probably a year and a half, but you will receive that money back dollar for dollar as a tax credit. Employers are now responsible to post a notice on site for the employee rights related to COVID. And the Department of Labor has posted signs and posters that are now available that have to be printed and put up on site. And I can send Robin that link and she can send it out to everyone. Okay, so now we've covered a lot of dense information on sick leave and benefit. And now what we're going to get into is an overview of the CARES Act. Now, this is a huge disclaimer here. This is not law yet. The House voted on and passed a bill. The Senate voted on and passed a bill. There is similar language in both bills. The Senate bill will now go back to the House. Language will continue to be worked on, and it seems that it will eventually be signed by the president sometime in the next 72 hours, and then we will have a law. Once the law is created by the signature, there is also guidance that has to be issued by different departments of the government, specifically the Treasury is one, where we will get more information on how this CARES Act is going to be interpreted. But let's go through the loan program that is available in the current iteration, because I think that's what all employers are itching to know about. What is this going to look like? So for employers of 500 people and less, the government is going to make available monies through the SBA program to take a loan to cover for, we're going to go over what's going to cover, but the covered period and it's different language in both of the different iterations of the bill, but the one that I have here on this slide is from March 1 through December 31st, 2020. I cannot tell you what dates specifically are going to be finalized, but that's what it's looking like right now. They are going to give you a maximum loan amount of 2.5 times the average total monthly payroll costs incurred in 1 year, okay, before the loan is made, and they're going to look at it year over year. And then they're going to, or 10 million is the lesser of. So it's the lesser of what you're actually paying out, and there's more actually items that have to fit in here, including additional payouts. So you're going to see what you can use it for. So mortgage payments, payroll, employee salaries, rent, utilities, and other debt. And again, this list might change a little bit, but basically all of your obligations to pay out from your business that are legitimate, you should be able to get replacement money for. Now, what is going to be forgivable, because that's what we want to understand, is what's the money that we can keep during this period if we want to employ our staff. We're going to get to that. Qualification right now under the iteration that we have is that you're in operation and you had employees that you paid salaries to and payroll taxes. And if you qualify, which any open business should, then you would be entitled to a loan from the money that's being given out by the federal government. There is deferral language in here, and it's different. One iteration of the bill has that you have 1 year to pay it back, because right now there is interest on it, which would be not more than 4% because it's under an SBA loan. The iteration that the Senate passed is you have a deferment for not less than 6 months and not more than 1 year to pay back and to pay back interest. There's no prepayment penalty. No lender can impose a prepayment penalty. And for eligibility purposes, they're going to require lenders to determine whether your business is operational in February. And there's going to be rehire language in here also if we've already terminated employees. So eligibility for loan forgiveness. This is the biggest thing that we all want to know. Is there money available for me to pay my employees now, keep them at full salary now, and I do not have to pay it back to the government? The language as it is right now is that a recipient who used funds for payroll costs during March 1 and June 30th does not have to pay it back, so long as they are not paying people who make more than $100,000 a year on an annualized basis. You cannot pay an individual more than $33,000 a year, $33,000 for the period of March 1 through June 30th. You will not be able to keep money where you might be double dipping, where you paid out under the Family's First Act for sick leave or for a caregiver time, because you will be receiving that back as a tax credit. So they're looking to make sure that there is no double dip. To apply for the loan forgiveness, so in other words, you have to apply for the loan, get the money, and then you would have to apply later for the loan forgiveness. You would have to submit to the lender of the loan application, so the bank that gives you the loan, you're going to give them documentation verifying the number of full-time equivalents that you have, employees. You're going to have to give over all your payroll tax filings reported to the IRS, state income, payroll, and unemployment insurance filings. So did anyone file and collect unemployment during this time period? Financial statements verifying payment on debt obligations incurred before the covered period, and any other documentation that the bank or the lender is going to require. So you can see there's going to be strings attached, and there's absolutely going to be accountability for the money that's being passed out. So it's a big decision. Limits on loan forgiveness. They're going to be capped at the sum of total payroll costs during the covered period, and the amounts of payments made during the covered period, and amounts of payments made during the covered period on debt obligations that are incurred before the covered period. Now, this is language that's right out of the bill that, frankly, I don't understand. And that means to me that it has to be clarified, because this to me looks like a mistake. I think that they're only going to reimburse for the payroll costs. This language that was inclusive in one of the drafts, that they're going to pay for debt obligations that were incurred before the covered period, just cannot be correct. So there's going to be changes before this is finalized and implemented. Loan forgiveness is going to be reduced by a percentage, accounting for the difference in staffing in year over year. So they're going to really be diving in. There's going to be a ton of auditing and a lot of process here. Reduction relating to compensation. If they have this language in here that there's going to be a reduction in excess of 25% of compensation in the most recent quarter, if employee was paid in compensation an amount. So for high paid employees, they plan on having some sort of reduction model for amounts paid out. And I'm not sure what that's going to look like yet. So, no one's going to know really what this is all going to look like yet until we have a final law and we have the language to interpret it, which is probably going to be sometime early next week and potentially evolving into the week after when we have the regulations issued by the different departments, including the Treasury. So determination for loan forgiveness. This is, again, more process and language that they have given us. They do say that they're going to make a decision within 15 days after the date on which the lender receives an application for loan forgiveness. So that's good. That might be pushed out, but that means you'll know immediately if the money you received and you plan on using is going to be forgiven. And if it is not, then you may want to take the money you received and just pay it back with no prepayment penalty. So that's a good thing. You could apply for it and then immediately ask for the forgiveness. And if you don't receive it, you don't have to spend it and you could give it back. They talk about the tax implications of the forgiveness on the debt, and they say it's going to be excluded from gross income for those of us who get heavy on our tax provisions. Exemptions for rehiring. So they've already contemplated, well, what if employers have already fired people and now they want to bring them back and use the money that's going to be available under the stimulus package as a way to pay for their staff to stay on and to receive money during this terrible time. And they've included language in the Senate bill that says that loan forgiveness under this section shall be determined without regard to a reduction during the time period that started on February 15th and ended on the date that is 30 days after the date of enactment of this act. So if you've completely glazed over during this conversation and the information presentation so far, what I'm explaining is the different mechanisms that the government has set out for us that allows our employees to receive money during this pandemic. And right now what we have is we have some additional sick leave that's available that the employer is paying, and how much depends on if it's now or next week. We have some stay-at-home leave the employer is paying. And now we have a salary replacement, a stopgap loan construct that's going to be finalized in the next week that is encouraging employers to keep staff on salary. And it will basically be income replacement for all staff making less than $100,000 a year, and possibly with a loan forgiveness. So we're getting through what's available mechanism-wise for your staff. Now, an additional supplement, and this is the last piece for us to consider as employers, is the supplement to unemployment insurance. Right now in New York State, unemployment pays out at a maximum around $5-something a week for employees. And of course, that depends on the actual salary level of the employee, and there's a complicated formula on how they figure out how much they're going to pay. And it would be reduced for individuals who have part-time work. The employee has to report on a weekly basis if they earned any income during the time period, and if so, the unemployment benefit in New York would be reduced. What's happening here, and this is the current language in the Senate bill, is that the federal government is going to supplement the state unemployment with an additional $600 per week. That is tremendous. It potentially takes an employee up from a $26,000 a year salary on an annualized basis to over $55,000 a year salary. So the unemployment benefit is the last piece of the puzzle for the employer to understand that the options are you can stay open possibly avail yourself of this loan construct, and your staff can remain at full freight, full salary, potentially, and you would be able to use these funds under the stimulus. We don't know exactly what that's going to look like. We have a pretty good idea based on the construct that's laid out in the language, but there are no guarantees. Under the flip side, if you're going to close and you do not want to maintain your staff and you do not want to continue payroll in the way that you have, because you don't want to face that, then you have the option to terminate staff, and there will now be additional monies through the unemployment program. So the government has offered us different ways to make our people whole during this time. I just threw this in here as a simple assessment for you on the current iteration of the recovery rebates. This is probably mostly for your staff. Taxpayers who are making more than $75,000 a year are not going to qualify, but those who are making less, the current recovery rebate looks like it's going to be a $1,200 check to an individual, $2,400 for a household, plus an additional $500 per child. And everyone who's under that salary level will receive that check. So moving back to some of the considerations for your practice, I understand everyone on this call, if you were unmuted, would be yelling at me that your broker has already told you that business interruption insurance is not going to pay out, that there's pandemic exemptions, and insurance is not going to bear the brunt of this. I understand. My recommendation, and many of my clients have already done this, is just get in line. Ask your broker again to please file a claim for you. So in case when the litigation ceases and all the dust settles, if insurance does have to pay, you had your claim in. You're going to work with your accountants and make sure that even though the tax payment dates have been pushed to July 15th, that any and all extensions and proper paperwork you need filed is already in. Because just because the pay date is off doesn't mean that the processing date is. Landlords are not negotiating, from what I've seen to date, by way of reducing rent, because they do not believe yet that they're going to have any help in their tax obligations and their debt service. So what I've been seeing is many of my clients have been very, very successful asking for a deferment. So I would recommend calling your landlord to see if you can have any sort of reprieve on what they're doing. Telemedicine. You are encouraged to do telemedicine at this point. There are relaxation of the HIPAA rules right now. The government's going to turn a blind eye. So basically you can use any modality that you can find. As your healthcare attorney, I would like you to try to find a platform that is HIPAA compliant, and to be careful with patient information and be mindful that we don't want to be too lax, because there could still be breaches during this time frame, and we would have to, I would recommend that we would have to deal with them. For telemedicine, this is basic coding advice that I wanted to just put up for basic visits. If there's anything specific that we want to walk through in the Q&A, maybe people are having a different experience with the telemedicine that they want to share, or platforms that they could recommend, that would be great. I want to go through the termination process in case anyone is concerned and thinking about reducing staff, which we can speak about if you would like. Now, the only people who are supposed to be coming in office are those that are necessary for you to perform emergency services. If you have a billing person who can work from home, he or she should stay home. If you have a scheduler who can work from home, he or she should stay home. If you have patients coming in for emergency services and you feel for you to safely sterilize your areas and for you to safely see your patients, you need 3 MAs to come in, then absolutely that's who needs to come in, because they are, by relation to you, essential, and the service that you're providing on that date is essential. So you can staff as you believe necessary to render your services to your patients. Now, if we are going to be terminating certain patients that, certain staff that we do not need right now, we are authorized to do so, of course. No one is stopping you from terminating, or some people are saying furloughing employees. I have an issue with the word furlough. I'll explain to you why. I am concerned that by designating staff as on furlough status, you are saying to the staff that you will bring everyone back at the same time, at the same rate, for the same amount of hours. And we can talk about it with the panel, but from what I've seen and hearing from many of my practices that I work with, is that they view this as a faucet that has been mostly shut, and it will turn on slowly. And the staffing that you will need is likely going to vary. So when you give the word furlough, that to me leaves you open as the employer to potentially claims of disparate treatment, discrimination, Department of Labor aggravation when this terrible pandemic starts abating. So I would prefer that staff at this point be on terminated status if you are going to be letting people go. Not furlough. I would prefer layoff or termination. I just think it's a lot cleaner, and then you can recall workers on an as-needed basis. You will be telling individuals that they may be eligible for unemployment insurance, and when you do terminate, you will be giving them, right here, you will be giving them hopefully this information, which you can get right off of the unemployment website, and telling them where they can file. Now, with the federal supplement for the unemployment insurance, the employee will not have to do anything else. The state is going to be managing that money and sending the check included in the state check or as a secondary check, but during the same week. And that was in the Senate iteration of the bill, and hopefully that will be adopted into law. Mandatory employee payments, if you are terminating, you would have to pay out any accrued PTO in addition to any government mandated sick leave if the person is qualified for that. And remember, the government mandated sick leave is for someone who is under quarantine or isolation with COVID, not someone who is home because they are not needed to render essential services in the practice. So there's a big distinction there. Health insurance, you have to speak with your broker and find out how long you can continue your current plan versus your current plan terminating for terminated employees and COBRA being their option. There is no barrier to employers paying a portion of COBRA. There is no requirement that an employer pay any portion of COBRA. If you want to offer as an additional benefit to employees during this time to cover COBRA, that would be your decision, and also would not be recoupable for you under the loan program that we talked about that's in the current bill. You are not required to pay severance to individuals unless they're entitled to contractual severance. And that's something else we should talk about. Some of you, or many of you on this line, have associate physicians that have an existing employment agreement. And under that agreement, you have to give them 30, 60, or 90 days notice. There's nothing in there that covers for this type of scenario. And they may be on salary. So if you're looking to terminate a salaried contracted physician, you are really asking them during this time to actually likely forego salary, but you may not be looking to terminate them. You're going to need the employee to agree. You're going to need the doctor to get on the phone with you and say, look, I understand this is a terrible crisis. I know I can't work, and I agree. And you're going to want to memorialize that in writing because otherwise you're in breach of contract for not paying them and not properly noticing them under the agreement. This is a sample, quick termination letter. Most practices will put a personalized introduction about, the state of the pandemic and just how terrible it is. And if they are terminating, it's typically they're looking to explain to the staff that, I'm doing so that way we have a place to come back to when the dust clears. And also we're not authorized to render any of our elective services, and that's why we're closing during this time. And that's usually part of the letter, or definitely part of the narrative and conversation. We went over the unemployment insurance. So for additional resources, I have some more things on the website, and anyone listening to this now for NYSOS, of course, is welcome to call me anytime. That's the basic information, Dr. Sun, that I wanted to cover, and I'm happy to open up the forum now to our panelists and for questions.
Thank you so much, Jennifer. That was a really great overview of what's going on in the legal climate. There's a lot of information there. For those of you who are in the audience, these slides will be available. The webinar is recorded. There is a area where you can ask questions if you'd like, but I want to start by opening it up to our panelists. On our panel, we have a few members from the board who are in several different practice type settings, as well as one of our NYSOS members. We have, for those of you who joined us late, we have Peter Menger, Ira O'Dell, Gary Hirschfeld, and Dan Rosberger, who graciously agreed to be part of this panel. So I wanted to start by perhaps giving our panelists a chance to give sort of a snapshot in terms of what your practice may be going through. You know, there are some who are in a hospital practice, academics, others who are in private practice or solo practice, and another who's in a group practice. So can I start with Ira?
Yeah, so I'm a physician at Northwell, as the past chairman of North Shore and LIJ. And I'd like to start out by asking a question that has come up in my mind, and I've brought it up with our current chairman, and I think it relates to everybody. And that's the HIPAA issues related to any member of the staff, whether it be a faculty member, a voluntary physician, an employee that's working in clinical care in any way. What is the rule in terms of whether we are allowed to tell other staff that may have come in contact with that individual about the fact that they tested positive or they may be positive?
Right, so it's Jennifer. So that's a good question. The way that we're being advised to handle it is to give the advice basically that while HIPAA is relaxed at this point, obviously protected health information is still sacred, and you are authorized to share the information that an individual on site has tested positive, but that you are asked not to reveal the identity of the individual. That being said, you know, if you're operational and one person is now on quarantine for 14 days and everyone else is expected to come back after 72 hours, after sterilization and reopening, it's going to be pretty clear who that individual is.
But there are peripheral people. So I can tell you, for instance, I'll give you just some scenarios. Somebody that may be in a practice that interacted with a resident. The resident brought a patient over from the clinic to another office that may be another different subspecialty in ophthalmology. And we don't know how many people any one individual has interacted with. And the only way we can get a sort of a handle on that is to know the individual and let everybody then try to figure out who might have interacted with them.
Well, the other position I should share before I turn it over to the doctors is that the Department of Health is taking the position now that everyone has been exposed and that there's no need to do any community tracing.
Okay.
That's how we've been operating. We definitely have patients as well as physicians, obviously in the hospital system, that have tested positive and have interacted with, you know, perhaps hundreds of patients within the hospital system. But the assumption is that there is, you know, it's community widespread, and we are not doing, we're not tracing.
Okay.
Dr. Rothberger is a retina specialist in Manhattan, and I think your practice has some unique characteristics in that many of your, patients are actually urgent, who are at risk of going blind. Do you have any sort of perspectives or concerns that you would like to share, which I'm sure are representative for some of us who are on the phone?
So in a retina practice, we deal with at least half of the patients, probably close to 2/3 of the patients who are in fact urgent. They need intravitreal injections on an ongoing basis. They need lasers. They need all sorts of interventions that can't wait or can't be postponed indefinitely. So we're trying to stay open, and the challenge for us is how to do that. We're talking about earlier the disinfection protocols, wearing gloves and changing masks and N95 masks. Well, we have a limited supply in a private practice, but we're going to run out reasonably soon, and there doesn't appear to be any mechanism for resupply. So these are going to be the challenges for us. I think we'll also have the economic challenges. We have a large staff and we have some additional associate physicians, but the bigger challenge is going to be how to actually maintain a practice in these situations. Knowing also that, at the moment we're dealing with prevalence, probably, we don't really know what the prevalence is, but probably in the 1 in 1,000, at most 1 in 100 range. But in a few weeks, in a few months, we're going to be dealing with every third patient having if they were tested, a positive result. And at some point, the estimates are as high as 80% of the population will be positive. So this idea of quarantining and sending people home with an exposure is going to be fundamentally different when 2/3 of the people in your waiting room are positive.
I totally agree. I think the way we practice is going to have to change entirely. You bring up a very important point about the lack of PPE, personal protective equipment. We are in the same boat at the hospital. I know that it might be, I don't want to say easier, but there's maybe a more straightforward process of getting some additional PPE to the hospital, but there are people on the front line who, we all have to reuse masks currently. We put a surgical mask over the N95 if we're in a high risk situation. I unfortunately, have to send out our residents to take care of patients in outlying hospitals where the situation is quite severe. So I know that Robin, our executive director, is working on it to see where these surgical masks, et cetera, that have been promised on their way to New York, it's coming. So we will try and send that information as soon as we have it. I wanted to give Peter Menger and Gary Hirschfeld an opportunity to either comment or ask a question. And Gary,
Peter Menger here. I'm a solo 2-office practitioner. I have an office in Queens as well as in Nassau. I've shuttered my office and I've laid off all my employees. I've transferred all my office phones and mail to my house, and I will manage emergency patients if I have to by going into the office if need be. The most important thing from with this is that I've transferred all my PPE to a local family practitioner who has absolutely nothing left. So if anything good has come from that, it's all the personal protection equipment I had in the office I've given to him. I've been increasingly working with telehealth, and it's been a challenge getting the patients to accept it. I am concerned about releasing my cell phone number, which unfortunately comes up if you're not careful. I'm using Doximetry, and if no one has that app, it is a very helpful app in cloaking your phone number. And additionally, I've been doing some FaceTime consults, and I do it through my iPad, in which you can cloak your phone number and just release your email address as the calling address. So those are just a couple of things that I've done to try and continue to deliver care in this.
To the phone. Mine, you'll hear me. Hi, this is Gary Hirschfeld. I would just like to say a few words about telemedicine and telehealth. Telemedicine and telehealth are two different concepts, and if you understand both, you may be able to continue a certain percentage of your practice. Telemedicine you can look at as telecall. These are phone calls. So initially what we were doing with our patients is telling them, the non-urgent patients, we'll reschedule you for 6 weeks, and then thinking in 6 weeks we might have to reschedule again. What we're doing now is offering a phone call with the doctor. So the patient's being said, look, doctor says you're non-urgent. You can reschedule. If you have any concerns, the doctor will call you at this specified time. The good news about that is our glaucoma patients that are seen every 4 months, we know they can go for 6 months, but they don't. They're used to every 4 months. And when they get a call from a secretary that says, doctor says he doesn't need to see you, he can see you in 2 months, they feel abandoned. They're like, oh my God, I need my pressure checked, even though you know better. So they ask for that phone call. The good news about the phone call is it's billable. It's billable as a telemedicine call. There are 9 codes, which can be used for, and I have these codes available for you, which can be used. It's based upon time. So 5 to 10 minutes, 10 to 20, over 20. And so you can have calls with all of your patients, every single patient. Post-op patients you can't bill for. There's some specifics about using these codes, which I won't get into, but they are available to you. Keeps you in touch with your patients. It allows you to reassure them that you haven't left them, and you get money and can generate some revenue. Telemedicine calls can be used only for existing patients. So an existing patient, fine. New patients, no. However, there is a method for new patients as well, and that's telehealth, which is different than telemedicine. Telehealth involves a video conference. So now you need a platform. It's not just a phone call. Used to be you couldn't use FaceTime or Skype because those were not HIPAA compliant. That's been waived. But you don't need to go there because there are 2 services that I've been playing around with and experimenting with called Zoom and Doxy.me. I can't get into the differences between them, but they are both HIPAA compliant and they both work. So you could easily get, just by logging on, you can make accounts and you can figure out how to use it and play with it, or call me and I'll help you. With telehealth, if you do video conference, the codes you use are actually E&M codes. You cannot use I codes with telehealth, but you can use E&M codes. And typically in ophthalmology, you're only going to be using 2 codes. You know, your 99202 for your new patient code. Or you might be able to get to a 3 code, but you're not filling out any of the bullet points of the exam. It's really your review of systems, past medical history, HPI, 4 bullet points. You go through it. I don't know the details. You might be able to get to a 3 code, but at least, and then, so you can get new patients this way. So a new patient calling in has a problem. You can give them a telehealth appointment. You can also, if the new patient really has an emergency, I lost my vision today in one eye and I can't see. Yesterday I could see. You should see that patient in person. But the patient who's inquiring about bilateral visual worse for reading for the past 3 months is 40, you can actually make a lot of progress with that patient. You're 40, it's okay, you know, and have a visit. You can bill for a new patient visit, and then you can schedule that patient for 2 months, or say, we'll call you, write a list. When you're back in the office in 2 months, call them, bring them in. So this is a system in which you can manage your practice, continue to connect with your patients, even have new patients, and generate revenue.
Thank you so much, Gary, for that perspective. I think there are a lot of questions on telehealth and telemedicine with the platforms. So that might be an interesting hot topic for us to get into, because you know, you can't go over all the details in the 5 minutes, but it is something that we might continue to use even after this crisis sort of slows a little bit. So I think that might be something that if our members are interested, we can get more information on. Any last comments from our panelists? I don't see any questions being asked from our audience. So I'll give perhaps Jennifer the last couple of minutes, unless the other panelists have something that they'd like to add.
Peter Menger, just one question. If you've already laid off your employees and they subsequently become COVID positive or are caring for someone COVID positive, are you then obligated to be paying them that?
You've already laid them off.
The answer is no. They would already be on benefit. They'll be on unemployment at this time, and then they'll be entitled to the additional supplement under the federal, assuming that that is in the final law that's signed. So there are actually a number of questions that are coming in. We don't have time to answer all of them because there are a lot of questions, but there are questions along the lines of if I've already fired individuals and now I want to apply for the loan, can I rehire them and have them have full salary supplemented? And the answer is, I think, yes. There is that language that's in the current iteration of the bill that you can rehire at this time and seek a loan. I am waiting for further clarity on what's going to be in the final law and then the additional regulations that'll be issued that'll give us more guidance on what that's going to look like for the loan forgiveness. So I think the main point is that what the government has stepped in to say is that your people are going to be taken care of one way or another, whether it's going to be through payroll for the employer, which the employer should not have to bear the brunt of the hit that's happening to commerce right now. But we will help the employer and reward the employer by giving them this supposedly almost free money to pay for payroll during this time period so they can continue operating and still receive the benefit of some revenue coming in, even if it's severely augmented. Or the employees will receive a benefit, albeit possibly potentially less, through the unemployment construct that's already established and supplemented by the federal stimulus that's going to be available. And for individuals that are on payroll working but cannot come in, then they have also set up this third tranche of the employer taking responsibility. So this is for someone who's not fired, but they would be entitled to certain capped benefits under the Families First Act that was signed into law last week. And that would be the 2 weeks of paid time off, which would be at 2/3 if they're caring for somebody else. And then essentially 12 weeks at $200 a day to care for a child who's out of school. And so I think that's the quickest summary that I could give on what's available for employees right now. So we're just at the hour mark, Dr. Sun. I know we had discussed that we can circle around once things are more final. And I can also collate the questions that we've received from the audience today and make sure that we've incorporated those into any future discussion we might have on the COVID environment.
Absolutely. Thank you, everyone. Thank you, Jennifer, panelists, our NYSOS members for taking out the hour to join us. Have a good evening. We will send out more information. I hope to do more webinars. It sounds like there's a lot of questions that have been left unanswered. I apologize, I couldn't see those questions on my screen, but it looks like Jennifer has them all. So be safe and well, and I look forward to hearing from you soon. Good night.